Good morning, good afternoon, good evening from wherever you're joining. Welcome to this session where we shall share lessons from PERFORM2Scale, experiences of district level management, strengthening intervention being scaled up. My name is Adeline Adiyija Kanemani, and I'm part of the Uganda country research team. Now, for some housekeeping rules. The chat function is not available today. However, please do go ahead and submit your questions and comments in the Q&A box below. The camera and the microphone have both been switched off, so no one can see or hear you. Also, please be reminded that this session will be recorded. And if you need to comment on anything about this session today, please feel free to comment via Twitter with hashtag Scaleup at PERFORM2Scale. In today's webinar, we'll start off by introducing the background to the project, the Scaleup framework, the teams that were involved, and our research methodology. We will also describe the main synthesized findings from the management strengthening intervention and how it has been scaled up over the 5 years in the implementing countries of Ghana, Malawi, and Uganda. We shall also have presentations from PERFORM2Scale participants on how they plan to or have scaled up the MSI in their respective countries. And this should lastly lead into the panel discussions, including Q&A. Now, to introduce the first speakers, Tim and Joe. Tim Martineau, next slide, please. Tim Martineau is based at the Department of International Public Health at the Liverpool School of Tropical Medicine in the UK and is the principal investigator for PERFORM2Scale. Tim's research interest is in health workforce strengthening in the context of the wider health system, which includes health systems in fragile and conflict-affected states. Today, he'll be outlining the background of the project, the scale-up framework, the teams involved, and our research methodology. Dr. Joanna Raven is based in the same department at LSTM as Tim. Joe is a health systems researcher with more than 20 years experience of research training and partnerships in Africa and Asia. She has a strong track record of developing the capacity of researchers, managers, and health workers, and has helped build an extensive network in health systems research at a policy interface. Today, she'll be describing the main synthesized findings from both the management strengthening intervention and the scale up over the 5 years that PERFORM2Scale has been running in the 3 countries of Ghana, Malawi, and Uganda. Over to you, Tim.
Thank you, Adeline. The PERFORM initiative on which this whole program was based was originally aimed at improving health workforce performance to support UHC. We felt that this needed to be done by integrating health workforce performance strategies and health system strengthening, and at the district level in decentralized contexts was the appropriate place for carrying out this work, particularly because of the available decision space of the teams. It's not going. The DHMT management strengthening is not a new thing, not a new idea. But what we found when we started this program was there was very little research done on it. And that's why we carried out the program in 3 countries. We covered in each country 3 districts. And this appeared to be a successful initiative, but to have greater impact, the PERFORM initiative needed to be scaled up, hence PERFORM2Scale. This is a project funded by the EC from 2017 to 2022. And this is under the EC's Horizon 2020 program. The African partners are the University of Ghana, Makerere School of Public Health in Uganda, who both worked on PERFORM, and Reach Trust in Malawi. They're working in collaboration with the Swiss Tropical and Public Health Institute, who also worked on PERFORM, and the Royal Tropical Institute, or KIT, and two Irish institutes, Trinity College Dublin and Maynooth University, with Liverpool School of Tropical Medicine, again in the lead for this program. So the aim of the program was to learn about Scaleup using a tested and wanted intervention, which we referred to as the Management Strengthening Intervention, or MSI. And we wanted to do this in different and changing contexts. I'll provide a brief explanation of the intervention, of the Scaleup, and how we carried out the research. The intervention, we report on the implementation of these management strengthening interventions, the MSIs, from 2018 to 2021. A set of guidelines for the MSI were developed from the PERFORM initiative based on the following principles. DHMTs choose problems to address, as this increases the ownership of the process. We didn't provide extra resources for implementations of the work plans they developed from the problems. Guidance was not to be too ambitious with the plans. This was is a learning experience, and the intervention would be carried out as a team to strengthen teamwork. And we would share experiences across districts, and therefore we worked in groups of 3 districts. We also recognized that strong facilitation skills were needed for this, and we needed to sustain a leadership role throughout the process of the implementation phase. The MSI is based on the core principle of learning through action and reflection using a problem-solving approach. Initial visits made by the research team and short workshops at the plan stage, with further visits and inter-district meetings during the implementation period, are designed to lead the DHMTs through the MSI cycle. And as DHMTs go through multiple cycles, they manage to get more depth to the management strengthening process, and the MSI becomes more embedded in their work. In terms of the Scaleup, after reviewing a number of options, we chose the ExpandNet Scaleup framework and adapted it for our use. This is the ExpandNet framework. So the MSI, the Management Strengthening Intervention, is the innovation in this diagram. The role of the, sorry, wheel's not working. Try. Okay, the role, sorry about that. The role of the National Scale-Up Steering Group, NSSG, as the user organization is to manage scale-up, taking key decisions on locations during the project period, in developing the strategy for expansion and sustaining the scale-up, including securing resources for beyond the project, and also to select and manage the resource team, which was planned to gradually take over the running of the new district. And this whole process is managed by the PERFORM2Scale country research teams. Our focus was on building the infrastructure to carry out the scale-up, so we needed to build the what we call the vertical scale-up, but also to carry out the horizontal scale-up, which is during the project and beyond, which is extending the use of the MSI to new districts, having developed the infrastructure with the NSSG. And finally, the context. We chose decentralized context because of the decision space, but we'll hear more about the changing context from the other presentations. We obviously needed to have a plan in our proposal for this program, and this was our initial guide. So working with groups in 3 districts, the plan was to take on 1 new group of districts each year to provide support up to the end of 2020, with the vertical scale-up process through the NSSG continuing the scale-up from 2021. However, because of COVID and other reasons, we continued to support during 2021, and you'll hear more on the scale-up stories in the presentations that follow. And finally, in terms of research, the 3rd component of the project covered both process and outcome evaluation using the following research questions. We recognized the importance of the context and carried out an initial analysis of stakeholders and experiences of scale-up based on reviews, reflections, and key informant interviews. The process evaluation looked at the implementation of the MSI itself, as well as the process of scaling up the MSI, and this largely used qualitative methods. And the outcome evaluation looked at the effects of the MSI and also the effects of the scale-up process and the costs. A tracking tool was used, and qualitative methods were supplemented by decision space assessment and several surveys. Thank you.
Hello, everybody. This is Jo Raven here, and I'm going to be talking about our findings synthesized from across the 3 countries. So next slide, please. So first are the findings about the management strengthening intervention. Next slide, please. Our research confirms the earlier reports of PERFORM that the MSI is an effective intervention for management strengthening. It improved the district health management team's skills and confidence in identifying, prioritizing, analyzing, and solving problems. Managers were positive about the intervention and in particular spoke about selecting the problems that were real and important to them. And this fostered ownership and commitment to the process. For some district managers, this approach for problem solving became embedded in their way of working. The opportunity to carry out multiple cycles within the project period showed how learning could be deepened, demonstrating a relative advantage over some other methods of management strengthening. The intervention did not need extra implementation funds, as Tim spoke about the key principles of the MSI. In fact, this was seen by many as a positive attribute. It actually contributed to some improvements in workforce performance and service delivery in line with the broader work plans of the DHMTs. Next slide, please. There were some improvements in workforce performance systems, such as more frequent appraisal, induction activities for new staff, use of attendance books and duty rosters, improved supervision tools. And this can lead to improvements in workforce performance, such as perceived reduced absenteeism. There was evidence of improved service delivery in the 3 countries. There were increases in health service coverage, for example, antenatal care coverage in Uganda, Ghana, and Malawi, TB cure rate in Uganda, neglected tropical disease detection rate in Ghana. Improvements in access to services was shown, for example, in one district in Ghana, by strengthening community health committee meetings and regular engagement of health staff with the community. Outpatient attendance increased, as well as community participation in health campaigns such as mass drug administration for neglected tropical diseases. These improvements were recognized in the annual district review and resulted being awarded best performing district in the region. In Uganda, for example, one district focused on tuberculosis, and during one MSI cycle, the cure rate increased from 20 to 41%. Having said this, it is challenging to attribute improvements in service delivery to the scale up of the MSI. Next slide, please. The MSI was guided by a detailed toolkit, yet it was adaptable to local needs in terms of duration of cycles, the nature of workshops and support meetings, and involvement of local stakeholders. So in Malawi and Uganda, the implementation period was extended to fit with the district's annual planning cycles, so from 8 months to 1 year. Research teams found that more time for relationship building with the district health management teams was needed. Uganda added a pre-visit before the formal orientation, and more ongoing support was provided through additional visits to the districts, or the length of the workshops was extended. In Uganda, as all participating district health management teams in one group decided to continue working on their chosen problem in the second cycle, a hybrid workshop was used combining the 2 workshops to analyze the problem and develop a work plan. As research teams gained a better understanding of how health service decisions were made at district level, other actors from the local government in Malawi and Uganda were involved in the MSI, in addition to the district health management team. So in Malawi, this was about the district council being more involved to support the implementation of the work plans. In Uganda, this included the human resource and planning officers, as well as the chief administrator of the district. So let's now move on to the findings related to the scale up. Next slide, please. We were able to achieve significant horizontal scale up and conduct the MSI in 27 districts spread across 3 countries over a period of 4 years, with 45 cycles implemented. This included running the MSI through up to 3 cycles in some of the earliest districts to be engaged. The major hindrance to horizontal scale up was the arrival of the COVID-19 pandemic in March 20. This both prevented the MSI support activities from taking place and understandably diverted the attention of district teams from the implementation of their work plans. Many of the participating district teams picked up the momentum for the MSI before the end of the project, implying that the approach was sufficiently embedded in their way of working. This was further demonstrated by the application of the approach to COVID-19 related tasks. So they learned from the MSI to make better use of available funds. Next slide. So now I want to talk about the institutionalization of the MSI in policy plans and guidelines, or the vertical scale up. In Ghana, the management strengthening intervention is not yet embedded in policy or guidelines. There are plans to further expand the intervention within the Eastern region. And as you can see in this figure, there are approximately 20 more districts to cover here. Integrate the intervention and performance indicators in existing performance measures in the region, strengthen the regional scale-up steering group to oversee implementation of the MSI, and develop training packages and integrate these into regular refresher trainings for district health management teams and regional directorates. Next slide. In Malawi, the zonal offices of the Quality Management Directorate are proposed as hubs for the scale-up, with the quarterly review meetings of these offices accommodating the MSI workshops as well as the inter-district meetings. This requires financial resources from the Ministry of Health, which is significantly dependent on the support of international development partners. However, satellite offices are not yet functioning fully across the whole country, and there are concerns about how these zonal offices will adopt this role. In addition, some elements of the situation analysis tool used in PERFORM2Scale, such as human resources, financing, and gender information, is included in the nationwide supportive supervision tool. You will be hearing more about this from Dr. Bongani. Next slide, please. In Uganda, the development of the Scaleup strategy took about 4 years. The health workforce performance component of the MSI is included in the newly approved nationwide quality improvement strategic plan and framework. The existing quality improvement and assurance structures at the national level provide governance oversight, and at the regional level, the quality assurance and improvement committees and community health departments within the 14 regional referral hospitals support implementation. The Uganda research team plan to be involved in the training, mentoring, and support of the personnel there to support districts in human resource management for quality improvement. Funding for the framework and cycles is not yet decided. There will be some government budget for implementation of the strategy in all regions, but additional resources from development partners may be needed. Dr. Namakula will elaborate on all of this. So next slide. I now want to go through 5 key lessons that we have learned about Scaleup. Next slide, please. Firstly, Scaleup is not a linear process. It's a bumpy road with advances and setbacks along the way, and we need to be robust, manage the frustrations, but also be persistent and continue dialogue with key stakeholders. Critical to this is having a clear shared vision among different stakeholders involved about how to institutionalize the intervention into existing systems, and this facilitated the Scaleup. So this is an understanding of where we are and where we want to go. And it took time to develop this shared vision. Next slide, please. The Scaleup approach needs to be flexible to the context and should be adapted as you go on the Scaleup journey. We needed to spend more time identifying appropriate existing structures to carry out the role of adopting and implementing the intervention at a larger scale and avoid creating parallel structures. For example, the functioning of the National Scaleup Steering Group had challenges, which were overcome by using context-specific structures. For example, regional level steering group in Ghana, and in Uganda, using existing structures, so the Ministry of Health technical working groups and a key coordinator to steer the Scaleup. Next slide, please. From the outset, we need to consider how the intervention aligns with existing or new policies and interests. This requires not only in-depth knowledge of the policy environment, relationships with key decision makers, but also continuous or frequent observation and scanning of the horizon for windows of opportunity and new and important stakeholders. For example, in Malawi, PERFORM2Scale and its MSI was aligned with national political interest and policies in improved leadership and management at the district level, which supported implementation of the Scaleup strategy. The Quality Management Directorate was convinced of the value of the MSI Scaleup and therefore steered the Scaleup with little involvement from the Ministry of Health senior management team. However, to get further support, which is essential for the Scaleup to be implemented, more information needs to be provided to a wider group of stakeholders, including funders and development partners, as they have influence over the health sector, particularly through allocation of funds. In Uganda, the link between management strengthening intervention and quality improvement was recognised, and the opportunity to input into the new quality improvement framework and strategy was grasped. Next slide, please. Evidence is needed to convince stakeholders of the value of the MSI Scaleup. Although we were able to provide compelling narratives on improvements in management, health workforce and service delivery, it was more difficult to provide robust quantitative data to support these narratives. Stakeholders in all countries are more used to or prefer quantitative evidence, but this is difficult to provide for complex interventions like the management strengthening intervention. We needed to think through who provides the evidence. Voices of the DHMT talking about the MSI and its benefits was critical, and you will hear this from Dr. Bekui later. Providing evidence early on in the programme, despite having evidence from the PERFORM pilot, was necessary, so some early data is key with regular updates. However, it's not only evidence that plays a role in convincing stakeholders of the value of the MSI Scaleup. It also depends on the mandate and position of the stakeholders and how they are viewed by others. Next slide. And perhaps our biggest lesson that underlies all the other lessons is thinking and working politically throughout the Scaleup process. We needed to identify who we should work with, who is interested, who has influence, who has power to make decisions and influence others. So working with champions, not to just support the MSI, but as someone who will actively advocate for the scale up of the intervention, understanding what interests them, why they want to do this, and leveraging their position, influence, and networks. We also needed to be able to anticipate changes in power relationships between key stakeholders and decision makers. And we also needed to identify and work with other stakeholders emerging as important, especially when contexts are changing. For example, the evolving decentralization and new government, as we saw in Malawi. So I hope this has given you a flavor of the PERFORM2Scale project, which our panelists will elaborate on. So thank you.
Thank you, Jo and team. Now that we're well versed with the PERFORM2Scale MSI, we shall now listen in on the implementing country experiences. Please remember to post your questions in the Q&A box, and these will be picked up during the panel discussions. So our panelists for the next session, we'll start off with Dr. Benedict Bekui. He is the Director of the Health Services at Atiwa West District in Ghana. His topic is on the effect of the management strengthening intervention on DHMT management, workforce performance, and service delivery in Ghana. The second panelist will be Dr. Justine Namakula. This is a country research team member from Uganda, and her topic is on the vertical scale-up of how the MSI was integrated into the quality improvement framework, but in an adjusted way, the trade-offs and compromises to achieve that scale-up. Justine is a health systems researcher from the Department of Health Policy, Planning and Management at Makerere University School of Public Health. Her work mainly focuses on health systems in fragile and conflict-affected settings, human resources for health, and has been on PERFORM2Scale since 2017. The third panelist will be Dr. Bongani Chicopulo. This is a resource team member from the Ministry of Health, Malawi. His topic today is on the scale-up strategy in Malawi, how it was facilitated by the Quality Management Directorate of the Ministry of Health and its future in the country. The chair for this session will be Dr. Maurice Cook. Maurice is a senior advisor at the KIT Royal Tropical Institute in the Netherlands. Her work mainly focuses on health systems research with a focus on community health, human resources for health, and sexual and reproductive health and rights. Maurice has been involved in PERFORM2Scale since 2017, and particularly in the initial context analysis and the process evaluation. Over to you, Maurice.
Good afternoon, ladies and gentlemen. My name is Benedict Richard Bekui. I'm District Director of Health Services for Atiwa West District, Ghana Health Service. I'll be speaking on the effect of the management strengthening intervention on district health management team, workforce performance, and service delivery in Ghana. So Ghana has a population of about 32 million people. We divided into 16 administrative regions. Atiwa West District is one of 33 districts in the eastern region of Ghana. We have a population of about 62,000 people. The structure and the function of the District Health Directorate has been set up to follow the health building blocks or the building blocks of health systems. So we, at the core of it is the leadership and government. We are the lowest administrative structure that interacts with the population directly with regards to health. And we provide leadership and governance in that area, implementing the policies and programs of the Ghana Health Service. We oversee service delivery. We have 19 health facilities that we supervise. And we also oversee human resource activities, the supply and distribution of medicines and vaccines, health data collection and processing, and also healthcare financing. Now, all these areas have peculiar challenges. In the area of service delivery, we do not have as many health facilities as we would have wished we have, and there are areas of our population that access to healthcare is still limited. We do not have as many community health nurses and midwives as would be desired. And in the area of financing, most of our funded programs are programs that are being implemented together with the regional and then the national Ghana Health Service structure. At the district level, sometimes we identify peculiar needs, but sometimes those peculiar needs go unfunded, especially if they do not tally directly with the regional and the national programs that are being implemented. Now, PERFORM2Scale has been instrumental in improving our work as a district health management team. It has opened our mind and given us ideas as to how we can improve on the kind of work that we do at the district level. And I would want to mention a few areas. In analyzing our data, it has the management strengthening intervention going through the first round. It has helped us to be able to analyze our data more consistently and thoroughly. So now we're able to identify challenges and institute solutions, observe how our instituted actions are affecting our targets, and then be able to adjust accordingly. It has also helped us to be able to work across technical areas. So at the Health Directorate, we have technical areas like disease control, health promotion, nutrition, health information, reproductive and child health services. Now, going through the management strengthening intervention, we have been able to work across these technical areas to be able to identify problems and analyze them. It has fostered teamwork in identifying the problems that we have, brainstorming and finding solutions. In the management strengthening intervention has also helped us to be able to utilize the resources that are available to us to achieve the new local targets that we set for ourselves by riding on existing funded programs to promote less funded and unfunded programs. So a typical example is that we had the opportunity to run a reproductive and child health program that was targeted at adolescents, and the health promotion unit was able to get on board to be able to also educate these adolescents on staying in school. The disease control unit was able to also get on board in encouraging them to take COVID-19 vaccination and get protected. And this has been very useful to us. Prior to the management strengthening intervention, one of the challenges would have been finding funding for such programs. So I'll stop here, and then hopefully if there are questions along the line, I would respond to them. Thank you.
Thank you, Dr. Bekui, for sharing your experiences with the management strengthening intervention in your district. We are now going to hear from Dr. Namakula about scale-up experiences of the management strengthening intervention in Uganda. Dr. Namakula, the floor is yours.
Thank you so much, Dr. Mary. In Uganda, we had an entry point for scale-up at national level, which was based on formation of the National Scale-up Steering Group, and it was informed by the guidance of the Director General of Health Services. So that group was comprised of the Permanent Secretary, the DG himself, and commissioners from the different departments in the Ministry of Health. And then we also formed a resource team, which was comprised of assistant commissioners and principal officers within those particular departments, with the aim of having a feedback after implementation of activities. But at the same time, we also were advised to use the structures that are existing. We were mainly making presentations to the technical working groups, one on quality improvement that was called standards, compliance, accreditation, and patients protection, as well as the Human Resources for Health technical working group. But in there, we had various adaptations around the entry points. So for starters, within the NSSG, or National Scale-up Steering Group, it wasn't functional as we had envisaged. And the reason was because, one, it was a parallel structure. At the same time, the people we had identified were busy people. So we ended up having a scale-up, a steering group focal person identified to be able to guide implementation, but also advise on how to move forward and feedback into the other senior management committee where the other people were seated. We could meet with them. The other issue then, in terms of not being able to have the NSSG functional, we had to use existing structures as advised. But the issue that was pertinent to the technical working groups meeting was that, one, you had to be a member of the technical working group, but also you had to make sure that you're invited. And the RRTs in charge of those working groups invited us. But within COVID-19, the focus changed, and these working groups weren't as regular as would have been prior to the epidemic. And then in relation to the resource team members, we had some hiccups there as well. The resource team members, at least two of them were transferred. One was transferred from Ministry of Health to Health Service Commission. Another was transferred to local government, but were advised to keep them as they were. The other issue was that they were busy people. So we were advised to pair them up and also send them activity schedules in time. That way they can plan more purposefully. And then were advised to also focus mainly on the existing structures for quality improvement. And there were advised to see how to begin introduction of an orientation of the regional referral hospitals. And by the time the project ended, we had started off with the Port Regional Referral Hospital. One of the key things that emerged during our technical working group meetings was that the MSI was quite similar to the PDSS cycle that was used in the QI, or quality improvement interventions. And that took us quite back because we were very confident that our MSI was as good as it could be. But then when we went back, we reflected as the action cycle informed us to do, and we got our niche, as I'll share later. The other hiccup we got was we had envisaged as PERFORM2Scale to have the resource team members to take over the implementation of Scaleup and roll it up to other districts. But they said they were unable to take it on, and they advised us to take that into the existing structures, which are for QI. And the actual opportunity arises that Uganda is moving into regionalization, and this is something that we're going to move up with as we implement the Scaleup strategy. Next slide, please. So on this slide, I am sharing what our niche was. Because in one of the technical working groups, I remember it was SMEA then, 2019, they asked us around the actual gap that we're feeling or the improvement. As you can see within this particular image, on your right side, above is the MSI Action Research Cycle that Tim shared earlier, and below is the PDSS cycle. So what we are adding on as PERFORM2Scale is the fact that we need to reflect and adaptively learn and implement the reflections, and decisions have to be guided by the reflections. But at the same time also, the need to focus on the human resource workforce, health workforce, who are basically the driver of service outputs, became a niche and a contribution to PERFORM2Scale, because previously QI has had more focus on the service delivery outputs. So as PERFORM2Scale, we are encouraging looking at the QI interventions with the NHR lens. So for example, if you want to look at immunization, can you focus on the staff that's supposed to have those outputs or the numbers made, and also give them a sense of direction and have them mentored and supervised, that way they can be able to perform better once they know their role. Next slide, please. So that is what Joe also shared earlier within the current and new QI strategic framework. And in the picture on your right is around the factors that influence health workers' performance. And the input I was talking about is more about sense of direction and competences, but also Uganda has been keen to do what they call onboarding. They keep on orienting health workers about what they're supposed to do, because some of them may leave, but also they may forget. Supervisors have to be able to ensure that these competencies are strengthened over time, and then they can perform. But once they perform, we also advise that the rewards and sanctions framework then get into place. But in most cases, there's a tendency to focus on the sanction, and that creates dissatisfaction among health workers. So we need to have an equitable package of the rewards and sanctions. Make sure you focus on either or, instead of only focusing on one, to be able to be fair. Next slide, please. So the challenges or the hiccups or the risks when you embed within existing frameworks, like for example, in our case, the quality improvement framework. One, not everything goes in when you embed. So one of the wise men on PERFORM2Scale calls it legitimacy lost for PERFORM2Scale MSI. But it is what it is when you combine it with someone who already has something existing and in depth. At the same time, the issue of resources is key. Joe shared that there are no finances. So when you embed, it means the decisions to allocate the resources to activities embedded then lies within the hands of the one that is in charge of the scaled up intervention. And in this case, the Ministry of Health and the Quality Improvement Funders and Implementation Department. Next slide, please. So moving forward, Joe mentioned that we hope to strengthen capacities of existing structures in terms of human resource management for quality improvement, and those are the community health departments at regional referral hospitals. But at the same time, make sure that we disseminate successes as well as contributions to quality improvements as by PERFORM2Scale widely through the national platforms. And these include the technical working groups I talked about earlier. And it is important for us to also look out for opportunities that can enable us to move this nice work forward by looking at who is attending those particular meetings. Next slide, please. Thank you. Over to you, Maris.
Thank you very much, Dr. Namakula. We are right away going into the Malawi presentation presented by Dr. Chicopulo. Please go ahead.
Thank you very much. I'll be sharing the bumpy road that Malawi has taken to scale up the MSI. And my name is Bongani, the head of norms and standards. We started implementing the PERFORM2Scale around 2019, and the initiative is in line with our strategic document. And when we started, it also coincided with efforts that we've been done in the country strengthen leadership, particularly for decentralized structures. The focus on DHMT was quite strategic because they oversee most of the services in the country, and also decentralization is maturing in the country. Throughout the implementation, we got good reception, despite that the initiative was a cost neutral approach, and the district were looking forward to the interactions. Next slide. So within country, we saw that there were a lot of things that we could get. We could get from the MSI approach, and as a country, we started discussing on areas that we can be able to adapt and scale up. We noted that the tools that were being used in PERFORM2Scale, there are some elements that we could take and adapt them into our integrated supported supervision too, and that was done. We also saw that the inter-district meetings were quite useful, and we decided to continue with those. But now we thought that they should happen at a zonal level, bringing together 5 to 6 districts. This was and the platform is the district health management quarterly review meetings. This was something that was being done some years ago, and we thought that we needed to revamp it and would use the integrated supported supervision results for the district to be able to identify system issues. And the implementation of the zonal meetings would be strategically coordinated by the quality management satellite offices, and they would also coordinate support to districts, where teams will go and support the district. We are considering that in country there was a lot of interest in leadership and management capacity buildings. We thought that we could use the National Scaleup Steering Group meeting to also ensure that we integrate the different interventions that were happening in country. And this committee has evolved into a steering committee for professional development. Next slide. It was quite strategic that this initiative was being championed by Quality Management Directorate. Of course, this was not easy because, as you can imagine, that leadership and management interventions are quite cross-cutting. And in the early stages, there were a lot of discussion which department can host this initiative. And at the end of the day, it came to a decision was made that QMD should champion it. And QMD was strategic in the sense that we are also responsible for coordinating integrated supported supervision, and it was easy to integrate into the current tool that we're using. And we also have got central offices in all zones that could coordinate this initiative. Next slide. So what were the lessons that we got, and which are informing the scale-up strategy, and what we're going to do in future is that, as I've indicated, we're going to continue with the inter-district meetings as district health management zonal meetings. These meetings are quite critical, but they are also resource intense. And as a country, we still need support from donors in the short to medium term. So we'll be aligning the focus areas of aligning the resources that are within country to ensure that the resources are aligned to this intervention, and we'll also be engaging the district to co-fund the attendance of these zonal meetings. Next. We also found out that the interministerial collaboration was very crucial, both at strategic level, at the steering group, and also at technical level, because it was quite critical in addressing some of the bottlenecks. But we noted that the steering group was also comprised of busy members, and going forward, we would want to ensure that some of the roles are kept to the minimum, and the frequency of meetings are also reduced, so that they can just focus on strategic direction of the capacity leadership and management capacity buildings that are happening in country. We also found out that we could not fix the membership of resource team, because district needs are quite different, and the support to district have to be tailor-made. And as a country, we transitioned to a coaching system where the resource team members are now being called coaches, and we have teams at the zonal level, experiences middle managers to support district, to support the districts, and the support would be tailor-made to the district needs. So in conclusion, as a country, we're excited to be involved in this initiative because of its hands-on approach to leadership and management skill development, and also its alignment to QI, as my colleague, the previous speaker also indicated. But I think the uniqueness was that this intervention was at a system level. It had a target. It had a target focus on the district health management teams. So thank you very much.
Thank you very much, Dr. Chicopulo, for this outlining the experiences in Malawi. I would like now to invite all of our panel members for a discussion, and also the audience to send in more of your questions if you have any in the Q&A. Maybe for this panel session, the slides can go off so that we can see each other. That would be nice. We have some questions coming in already. I just wanted to start with Dr. Bekui. Your experiences with the management strengthening intervention at district level in Ghana are very valuable. And I was wondering, and I think it is also relating to one of the questions that was already asked, there are many different interventions trying to capacitate, strengthen DHMTs, strengthen management. And we are talking here about the MSI of PERFORM2Scale, which used an action research cycle and which used inter-district learnings. To your experiences, how is the PERFORM2Scale MSI? How did it differ maybe from other interventions in this field? Can you say something about that, please? Dr. Bekui, are you here? While we are waiting for Dr. Bekui, maybe we can also focus on another question that was asked by Shahid Iqbal, and that's also a question about DHMTs, and it was posed for the Uganda setting. So Dr. Namakula, to what extent do district health management teams in Uganda have the decision space really to make their own decisions? Can you say something about that? You are muted.
Thank you, Mary's. It depends on the decision that they like to make, because decentralization gives them decision-making space within management of health services. So what we find is that they work within the general system and they need to align with the broader local government plans and expenditures as well. So in terms of resources, because of the resources which enable the decisions to be made or implemented, the decision space is limited. But what we did as PERFORM2Scale was to enable them to realize what space they had, decision space they had. Because initially it was there, even the issue that was there, some of them were unable to realize that they could move A, B, C, D. And examples I can give included issues around lobbying their administrators to help with memos, for example, around absenteeism in terms of number of days worked, and others were more about the DHOs, for example, asking their leaders to be able to support performance management training at the district. So they can have activities, but they need to ensure that they embed within the broader district budget. And this is where other extended stakeholders, which we call the extended DHMT, like the planner, the COW, the other politicians, the EOC5 come into play. As PERFORM2Scale, we ensure that we bring on board all those stakeholders, that way they buffer and bolster the decision-making space as a whole, instead of having the DHMTs be on their own as a small group. Over to you, Mary.
Thanks. Just to check if Dr. Bekui is around. It seems not. Maybe he has some internet connection troubles. Let us, John, maybe move on to Dr. Chicopulo, the Malawi experience. And you have outlined how you envision the scale up of the MSI to happen from now, the embedment of the MSI in the satellite structures. But we also know from the Malawi experience that you have been collaborating quite a lot within this project with the Ministry of Local Government and Rural Development. This ministry is very important because they are in charge of decentralization, and DHMTs officially fall under the district council, so under the District of Local Government. Can you say something about how the Ministry of Health and the Ministry of Local Government have collaborated on within PERFORM2Scale, and how this coordination worked, and maybe also some of the hurdles that were there in that sense?
Thank you very much, Chair. I mean, starting with what worked. For the Ministry of Local Government, I think they were very keen to be involved in this initiative because it was strengthening decentralized structures. And during implementation, they were also a key facilitator in the scale-up process. As I've indicated, that decentralization is taking hold in the country. And the involvement of Ministry of Local Government provided credibility to this intervention because they were able to guide at district level, that ensuring that the implementation is aligned to decentralization policy. Even at national level, they provide valuable guidance in terms of ensuring that the intervention is quite aligned to the decentralization policy. So they provided value to the interministerial collaboration. I think the only issue that was a problem in the collaboration, interministerial collaboration, was that the strategic engagement of the NSG members, as I indicated in my presentation, that we noted that they had a lot of roles with busy schedules, and because of their busy schedules, they could delegate some of the meetings. And going forward, we would want to reduce the roles to more of strategic engagement. Thank you. Over.
Thank you. And there was also a question to you from Godelieve van Heteren. And she was asking about, there are many initiatives in quality improvement. So as a quality management director, for sure, you have a lot of different projects and also quite a lot of different development partners that you are working with. How do you deal at your level with trying to integrate these different efforts also from partners, how to coordinate them? And in particular, when projects run out, like when they are done, like PERFORM2Scale was a 5 years project, when they stop, how do you ensure that things are moving forward? Can you say something about that?
Thank you very much. I think that's not an easy question to take, but I think as a quality management directorate in Malawi, I think is about 5 years old. And what we did when the department was formed, we sorted out, we developed strategic documents to provide guidance, and I think that this gave alignment. We were able to align our implementing partners and all the stakeholders that are interested in improving quality in the country. And we also went ahead to harmonize the quality improvement approach in the country, because what we noted was that there were different quality improvement approaches that were being implemented, and that was the first thing to do, to harmonize the QI approaches. And through the technical working group, the regular technical working groups, we've been engaging with partners, sharing experiences of implementation, and also ensuring that the implementation is aligned to our strategic documents, and there is also no duplication. And without beating much of our drum, but I think as a department we've been trying to be in the lead in terms of quality improvement initiatives, and I think this aligns easily partners to come on board. Thank you. So maybe just to continue in terms of continuation of initiatives. This is not easy in our context because we mostly our health system is resource constraint, and I think the question always arises when projects like this, great projects, are going to end. How do we continue them? And I think for PERFORM2Scale, learning from the PERFORM2Scale initiative, what we have done, and if you note in our Scaleup strategy, we're trying to integrate within existing interventions, so that we should not require extra resources. And that also creates sustainability, ensuring that we're aligning the delivery of the interventions within the healthcare system delivery. So I think that is quite crucial. It is not easy, but I think in our context, it is quite crucial to ensure that we are integrating the available interventions that already have got resources. Thank you.
Thanks. Yeah, it's all about integration and scale up, and also a little bit like integration of maybe certain elements of an intervention, or integrating the intervention in its full into existing structures. And we have seen from previous presentations in this webinar that in every country, the journey was different, and different aspects were being integrated into existing frameworks and structures, like in Uganda and Malawi. We have several questions from the audience, and that is more about the intervention, about the effects of the intervention. And we have heard from Tim in the beginning that indeed a process and an outcome evaluation was conducted to see what are the outcomes of the intervention and its scale up, and also how did they come about. And there are several questions, first of all, about maybe how did the intervention impact the DHMTs? So we have heard about teamwork, but can we also say something about, management competencies? So that's number one, in your experience. And then number two, did we see any effects on service delivery? Of course, that's quite distant, quite difficult to say, but maybe can respond on that. And then there was a particular question also about whether the intervention increased decision space of district health management teams. So it's an open question for all panelists to reflect upon the effects of the intervention, the management strengthening intervention. Who can I give the floor? Justine. I think you are still muted.
Sorry, I'll talk about two things. I'll first of all have a comment on effects on service delivery, and then I'll talk about whether the MSI increased the decision space of the DHMTs. In relation to service delivery, the effects on service delivery, we cannot, as PERFORM2Scale, attribute all the improvements in service delivery in those districts where we participated on PERFORM2Scale. But we can concur and agree that within our intervention, having the DHMTs plan together, reflect together, they were able to together come up with more feasible solutions within the limited available resources and be able to plan better. So planning and identification of the problem were key things. And we think that these HR issues are basically in the process side of things. And these are things that should be appreciated as we talk about the particular effects. For example, Luwero district was able to have an HR lens into absenteeism. They tried to, they were focusing on improving the TB cure rate, and they also had to focus on all the health workers that are responsible in TB, within the TB cascade, right from the registrar all the way to the clinical officer and to the laboratory officers. So in this case, as they implemented their MSI, the first cycle and second cycle, you would see the curve for TB cure rate increasing progressively. And there we can say that was a contribution to the overall service delivery output. But of course, we know that they are also implementing partners that are supporting these districts and giving them money to do more tangible output. So for us, our focus was mainly within the planning side, the reflection side, and decision-making, and also trying to have HR issues aligned and performance also aligned. So in relation to whether the MSI increased the decision space, I would say no, because that wasn't the main aim of PERFORM2Scale. But what we observed as we implemented was that PERFORM2Scale increased the awareness, the DHMT's awareness of the decision space. And I could highlight areas where this did. For example, areas around HR forecasting and analysis of the gaps, areas for performance management in terms of providing them a sense of direction, but at the same time also areas at the end of that performance management process, rewards and sanctions, that DHMTs had some decision space around there. But we also realized that, and this was made clearer when the RRTs began explaining the policy issues, because we used to go with them to implement. But we also realized that as DHMTs on their own, nothing would move. Their space was limited. And therefore, I would boldly say that the MSI highlighted the importance of teamwork. And that is when we're able to bring in, as I said, the other district stakeholders, the board holders like the COW, the planners who would enable them to integrate the MSI activities in the routine budget and the plan, but also the human resource officers who would help them to highlight the key issues for human resource. But so teamwork was one of the cushions that enable the DHMTs appear as though their decision space has been increased. But actually we know that, and we observed in Uganda that it was mainly an increased awareness that they can do ABCD, but also when we involve so and so within the district team, we can act as a team and appear as if our decision space has increased, but actually it helps us to be entrepreneurial, but also innovative as a team. And yeah, so I think those are submissions. I know that there's another question from the group. I think I've tackled both effects and the decision space. Over to you, Maryse.
Thank you, Justine, and sorry to interrupt you. I panicked a bit because my internet is unstable. But I see that Dr. Chicopulo also would like to add to this. Is that true? You raised your hand.
Nothing to add. We had similar observations, particularly for the decision space.
Mm-hmm. Okay, thank you. And there was also a question about transfers of DHMT members sometimes being difficult. Yes, that was also experienced within this project. And how we went about it is more like providing inductions of new members, and also the resource teams were instrumental in doing this. Just in between, I want to go a little bit back to the scale up, because PERFORM2Scale, as the name implies, studied and monitored scale up of the management strengthening intervention. The management strengthening intervention was already piloted before this project started from 2011 to 15. It was found, to have positive effects within DHMTs as well as further down towards health worker performance and service delivery. That's why it was decided to scale it up in those 3 countries that we were talking about. And we have heard from Joe.
Sorry, we seem to have lost Marisa. Her internet seems to be unstable. Perhaps we could just go to another question. Somebody asked, Maureen Chirua asks, from the presentation, there is an acknowledgement of challenges associated with managers not being available or ending up delegating the extended DHMTs. Without their involvement, how do you think sustainability will be ensured? Sorry, Marisa, I took over when you dropped out.
Thank you, Tim.
Justine, would you be able to address that? You're on mute.
Tim, I missed out on the question as
Let me
it was interrupted by someone. Can you please repeat that?
Yeah. This is from Maureen Chirua. From the presentation, there is an acknowledgement of challenges associated with managers not being available or ending up delegating to extended DHMTs. Without their involvement, how do you think sustainability will be ensured?
I'm not sure which managers they're talking about. Are you talking about people at the Ministry of Health or people at the district? Maybe Maureen can first clarify that before I make my response. But the issue about delegation, I don't think it was delegation per se. It was co-opting them onto their onto their teams in relation to which problems they were able to analyze and address. That way they can identify solutions together. There was nothing like delegating. It was basically teamwork. And every time we implemented an MSI cycle within each district, the role of teamwork became more pertinent, that it is not only about delegating to one, but at the same time, as PERFORM2Scale, we endeavored to involve as many DHMT members as possible. So I saw someone there indicating in the Q&A box a question around transfer of DHMT members. Since most of them were always there in the orientation, in the dissemination of the plans, so every time we went into the district to make a support visit, we would call upon them to give them updates. So it was easy for us to have anyone on the team, and whoever had the competencies required for a particular MSI problem that they were addressing would always come in, but already they knew where we're coming from. So there wasn't like anything like extension. And I could say, and I could applaud the managers of the districts that we've implemented in for their leadership role, because without leadership, the MSI team may not really work. So DHO's leadership was pertinent, and also they were very patriotic in terms of how they reacted to issues during the implementation. So it wasn't like they were delegating anything.
Thanks a lot, Justine. And sorry that I disappeared. I was just introducing my question about Scaleup and about that we are a research consortium, and that evidence, we always think that evidence is very important, that people should get convinced about an intervention and that then Scaleup will go smoother. Of course, there's more than evidence, there's also relationships and acting upon the context. But when we look at evidence, what type of evidence do we need? By whom should it be presented? And in what way do you think that Scaleup basically facilitated in your context? Maybe we start with Dr. Chicopulo. What type of evidence does the Ministry of Health need, and how should it be presented?
Thank you very much, Chair. I think largely, considering the intervention, would be working with qualitative evidence. But maybe just to expound from evidence, I think first of all, for what policymakers are looking at is that is an intervention aligned to the strategic document. Yeah. So for Malawi, I think it was easy. The intervention was aligned to the strategic goals for leadership and management improvement, and also strategic goals within the quality management strategy in ensuring that we are implementing QI. We're using QI's tools to make improvements. So I think that was sorted. The other evidence, which is quite critical, is that to involve implementers to tell their own stories. Yeah, so we need to be able to support implementers to share their stories, the success stories. I think there are a lot of success stories, and if we create platforms where they themselves are empowered to share their stories, I think that is critical, and we use that also in Malawi. The other issue is also about leadership being cross-cutting. There are a lot of interested parties, and I think to ensure success, and this was also an issue in Malawi, you need to map the key stakeholders and ensure that there's inclusiveness during implementation, consultation, because this will remove unnecessary bottlenecks along the way. This is not easy to do, but it's about politics and power plays, ensuring that who are the key stakeholders to ensure that these interventions, intervention like this is implemented and is successfully implemented. The last thing is, how are you going to sustain? And I think this is an important question that policymakers will always ask, asking us to scale up. Where are you going to get the money? So if you have got a good plan in terms of integration, looking at the available resources, aligning to the healthcare delivery system, I think that allays the fears of where the money is going to come from. Yeah. So I think, in a nutshell, I think these are the aspects. Yeah, you have the actual evidence of the success of the interventions and other issues that support to ensure that these interventions is successfully implemented and is taken up in the country. Thank you.
Thank you very much. And one of our audience members, Margaret Gaffrey, also points to different types of evidence. For example, annual health sector annual review reports, but also district league tables, and whether the outcomes of the intervention were also captured there, and whether this also further facilitated or supported scale up. I know, as Dr. Bekui is not with us anymore, unfortunately his internet connection is not good enough, but I know that in Ghana, some of the districts that were involved in PERFORM2Scale indeed increased their position in the district league tables, so to say. So that was also an interesting finding. However, in that context, that this did not necessarily lead to supporting scale up, as we have seen from the presentation in the beginning, that scale up in Ghana of the MSI is still really much more in its starting phases than in the other two countries. I don't know if any of you, Dr. Namakula or Dr. Chicopulo, would like to say something more about this before we are going towards an end of our panel session about, capturing the outcomes in maybe annual review reports or district leagues tables.
We have also had issues with presentation and updates in the technical working groups at the national level. And this evidence is closer to the senior management committee, because when you present to these committees, the end in mind is that they'll give you a leeway or a path to permission to then move ahead and present that evidence. There's something about evidence that came to my mind, and I think we have been also reflecting as CRT here. One of the issues we found to learn about evidence is that it should not only be positive, but should be balanced, showing successes, challenges, how those were addressed, but also lessons learned. That way, whoever listens to it has something to pick from it. Other than when it is a bit positive, everyone will wonder why is it that the context was just aligning to only your objectives and nothing else came about. But then the other issue about evidence was that in Uganda's experience, because when you have QI, qualitative improvement, the orientation is within the service delivery output, which, as you may see, the district league tables are basically numbers. But I think the appreciation here, and I'll add to what Dr. Bongani was talking about in terms of qualitative, is that success stories are important, but also qualitative evidence is important, because matters of human resource management are necessary to be counted. Not everything that is counted, they're not counted, doesn't matter. So human resource management is mainly about the processes, and these are rarely reflected upon. You can only address those particular issues when you listen into the stories and pick up on the context around which, for example, those service delivery outputs came about. And so we need to have a complementary balance of the evidence when we are having presentations to the particular groups. And of course, the voices of the DHMTs have worked for us before. I remember we took one of the DHMTs from Luwero one time to the SMEA working group to present their experience, and it was quite good. And so I think that is something, it's a habit, a practice that you can always keep on. But also other factors include relationships. When we start implementing a 5-year program, you need to focus on the relationships. Those act as social capital within the program. In particular, for example, why you are not necessarily initially members of the TWGs. These particular resource team members, for example, and resource focal person, our relationship over time has enabled us to identify windows of opportunities. And that is how our window of opportunity actually was observed. So it is, those are the small things that matter, as I would say. Over to you.
Thank you. Thank you. Well, we are approaching the end of our panel session. We have heard that the management strengthening intervention was positively received by DHMTs in the 3 countries. And from Dr. Bekui in the beginning from Ghana, we have heard that it led to creativity within the teams in implementing their work plans and also finding resources to do so. And in terms of scaling up the MSI, I have noted down here the term bumpy roads. I think it was used by several of us. The road that we saw in one of the presentations was actually not a bumpy road. I found it quite smooth, but a bumpy road, yeah. In that sense, there's a lot to think about and a lot to take into account when scaling up an intervention. We need to do stakeholder mappings, key stakeholders identifying, but also go beyond that, really understanding the interests of key stakeholders and the politics and power relations between those stakeholders, and then act upon that. Because as people that are steering scale up of the interventions, we are also part of that group of stakeholders and power relations between them. We have also heard that in the different countries, the scale up journey went different. Like in Uganda, more existing structures were used to steer the scale up, such as technical working groups, while in Malawi, the group that was actually installed by the project was more in the driving seat in the scale up. And we have also seen that there are different extents of scale up, or maybe integration of different aspects of an intervention versus complete integration of the complete intervention. And that has also turned out differently in the countries. I think that is about my summary. Thank you very much for being part of this panel. The PERFORM2Scale project is almost ending, but as we know, we are very much in touch with each other, and we are going to see if the horizontal but also vertical scale up of the management strengthening intervention will proceed in the coming years. We will keep in touch with each other. Thanks for the audience to attending this meeting, this webinar. You can find more information about PERFORM2Scale and other resources to explain some of the aspects that we have touched upon today on our website that you can see here. Madeleine, over to you.
Thank you, Maryse, and thank you to all the panelists and everyone who has presented today. Thank you to the audience for sparing the time and attending our webinar. For those whose questions have not been answered, this will be followed up and posted on the PERFORM2Scale website. And while you're on the website, feel free to browse through our toolkit that should be loaded on there next week, but there's some papers, briefs, and our synthesis report is on there. Thank you all and goodbye.